Let's just check. And then this would be the mic that actually goes for the recording. This one's kind of crummy. You have to like speak like really close into it, or you can just shout. Yeah.
So fancy. Do I need to hold it, or is it?
It's just like clip it on.
Okay.
Are we live? Oh, Josh. No. Can you change the title? We are live, but it's the wrong title again. Because currently it's coming up as a Tute. But
It's okay.
yeah, it is recording. Alrighty.
Okay. Okay, so we'll begin? Yeah? Alright. Shh. Okay, cool. So hello, I'm Amy. So I'll be doing a Tute, guys. Shh. So this is targeted for your BGD content. That's what we'll be doing for this week. So for today, I thought we'd go through the more OBGYN part of it, and then tomorrow we'll be going through the PED section of it, okay? Just because the BGDB Clinical Skills Guide, it has a lot of things to do for this course. So instead of rushing everything in 1 hour, we thought it'd be better to split and have two different types of tutorials instead. So for mine, I'm focusing more on the OBGYN sort of thing. And yeah. So with OBGYN, the reason why some people find it a bit difficult is, first of all, the history part of it is quite different, right? Because you still have to do your history presenting complaint, your past medical history, past surgical history, family history, medications, all that. But you also have specific types of histories that you also need to add in on top of that, okay? So for the first part, we'll just be going through the 3 extra types of histories that you might need to do for an OBGYN station. And then for the examination component, we'll just be going through urinalysis, okay? So first thing is a menstrual history. And just another thing of why histories might be a bit difficult for OBGYN is because some people might feel a bit awkward about it because the topic might be a bit touchy. People might not know, oh, how do I frame this sort of question? How is the patient going to react? What do I need to say? That sort of thing, okay? So the main thing for history taking is that there's a reason why you're taking history, right? Your patient is presenting with some complaint or some illness, and you're trying to help them figure out what's wrong so you can give them the right treatment, medication, whatever, to help them go back to their normal lives, okay? So because of that, whenever you're asking a question, just know that there's a reason why you're asking it, okay? If you feel awkward, it's because you're either asking the wrong question or you're not asking in the right way, okay? So with OSCEs, the patient actors are always going to be nice. However, in real life, if any of your patients are ever like, oh, why are you asking me that sort of question, you always just put it in the perspective of all the information or everything we're talking about today will be confidential. The reason why I'm asking this question is because I just want to get a better idea of what's happening so that we can sort of see what we can do in order to help you with the issue that you're facing, okay? But anyway, so for a menstrual history, so if you want to think of a way that you can go through it, or the way that you can sort of start it, obviously, you wash your hands, introduce yourself, and you can say that because of the symptoms you're experiencing, I would like to ask you some questions about your period. Is that okay? Alright, so things that you want to talk about in a menstrual history. So it's important that you guys actually know what normal actually is. Okay, so periods are they're quite variable. Like, I double checked all of the normal ones because you're not really sure what the range is, and the range can actually be quite normal, okay? So the first thing you want to ask is their menarche or their first period. So normal is about 9 to 15, average is 12 to 13. If it's anything outside of the range of 9 or 15, you might think that there could potentially be any hormonal imbalance there, okay? You also want to ask when their last menstrual period was, just in case they might be pregnant. You also want to ask up the length of the cycle, and this is taken in days. So normal is about 2 to 7 days, and you might just want to ask if there are any sudden changes because that might alert you to some issue, okay? Regularity, so essentially most periods should be about 24 to 35 days cycle, 28 days is average. So how you can ask about regularity is you can just ask, can you actually predict when your period will come, because that suggests that it's on a regular schedule, okay? You also ask them about the flow. So people usually ask flow by saying, how many pads or tampons do you use a day? I don't really like that question because I feel as if everyone uses different types, different absorbencies, people change them like in different frequencies. So I think a better indicator is just asking, how often do you need to change your pad or your tampon, okay? So normal is about 3 to 4 hours. If they're changing their pad every 1 to 2 hours, that's when it's quite heavy, right? And you can just sort of think how that could be quite inconvenient if you have to go to the toilet every 1 to 2 hours because that's how heavy your period is, okay? And the reason why we ask about flow is because if they have heavy bleeding or menorrhagia, if you want to use the medical term, that might suggest that they might have an underlying gynecological issue going on, such as endometriosis, or it might just even mean that it's normal, but you might just be worried that they might be at risk of being iron deficient, okay? Something you might want to also ask is about the consistency. So if they notice any large clots, because this could be a sign of endometriosis. Okay. So just a warning, you don't need to know like if large clots means endometriosis for OSCE's exam. I'm just putting it this way because this is what you'll need to know for the third year exams anyway. And I think that if you guys know what you're looking for, you guys will know, okay, cool, that's why I need to ask this question about do they see any large clots in their period, that sort of thing there. Okay. Also, if you have any questions at any time, feel free to let me know. So next thing is symptoms. Okay, so with the menstrual period, there are associated symptoms which are normal and fine, and then there are symptoms which aren't okay. All right, so you need to know which ones are normal and which ones aren't. Okay, so associated symptoms which are normal are menstrual pain such as cramping, breast tenderness, lower back pain, physiological symptoms, mood swings, food cravings, that sort of thing. Okay, so if they experience any of these symptoms, then it's okay. And when you are asking the question of do you experience any symptoms on your period, most patients will be like because I have to think about it. So it's easy if you just say, oh, you know, do you experience any menstrual pain, breast tenderness? If you actually give them suggestions, then they'll be like, oh yeah, cool, yeah, I have that, I don't have that, I have that, don't have that sort of thing. So you might just want to flag for any of your worrying. Yes.
Oh, sorry, you know you're saying like instead of asking them,
Yeah.
just give them examples.
Yeah.
Are you not going to start with an open question?
Oh, okay, cool, yeah. Okay, I guess you could ask them like a more open question, like, oh, do you notice any extra symptoms during your period? If they're a bit confused, then you might want to like suggest them some, that sort of thing. Okay, yeah, good question. So for some of the more worrying symptoms, so menstrual pain, so we noticed that was something that I said was an associated symptom was normal. So cramping is normal. However, the pattern of the pain might suggest it's something else. So cramping occurs because the uterus is trying to get rid of all the lining and shed everything. Okay, so if your cramping is more intense at the start of your period, that's okay, because remember, your uterus is trying to get everything out. Yeah, if the pain gets worse as you progress through your period, that might be a sign that it might be endometriosis. Okay, so that's important because they might say that they have menstrual pain. You might just want to characterize it a bit because endometriosis is underdiagnosed, and one of the reasons why is because people think that menstrual pain is normal. That's why you need to sort of think, okay, cool, but what's the pattern? And if it's really, really intense, then that might be a sign that it's something else and it's not just normal menstrual cramping. If they suddenly skip periods, I mentioned that twice, but if they're suddenly skipping periods, or if their period used to be regular but now all of a sudden it's not, that might be a sign that something might be going on. If they have bleeding between periods, that's a really red flag sign. Okay, so bleeding between periods can be anything from the fact that they might have missed their pill or they might have changed their contraceptive. They could have had an STI, cancer, injury, pregnancy, ectopic pregnancy, that sort of thing there. Okay, so one of the things that you really want to check for in a menstrual history. And also, this is just stuff that I just added on. So if they're over 25, you just want to ask them, have they ever had a pap smear before? So remember that they used to have the old pap smear system and then they changed it to the one that we have now. So you have a pap smear if you're over 25, or when you're sexually active, whichever one comes later. And if they ask you any Viva questions about pap smears, which they do like to ask, it'll be stuff like, what's the change? So before, they need to just check if there are any of your epithelial cells which change, which might indicate cervical cancer. Now they're actually detecting for the presence of the HPV itself. Okay, so that's a difference. And also this time, instead of having it every 2 years, it's every 5 years now. Okay, and under a menstrual history, you might also want to ask about contraception. So what contraception are they using? Have they used any other types of contraception before? Did they have any issues with previous contraception, such as bad side effects, that sort of thing there? And as part of a menstrual history, you might just want to ask about if they've ever been pregnant before, so gravidity and parity. So this is something I'll go through more in the obstetric history, but gravidity is essentially how many times have you been pregnant, and parity is how many times have you given birth. Okay, and also just as a side note that I thought I'd add on, so I've never asked anyone about their menopause or symptoms or anything like that, but just as an extra part which should be included in a menstrual history, obviously if they're coming to you with menopausal symptoms, you want to ask how, at what age do they go through menopause. So menopause is having no periods for more than 12 consecutive months, and you might just want to ask the symptoms. So know that there's vaginal dryness, there's also hot flashes, libido changes, and this can be quite confronting. So if you ever are asking anyone about menopause, which is very unlikely for the OSCEs, you might just want to ask about how they're coping with it and how they're dealing with it, that sort of thing there. Okay? So yeah, so this is menstrual history. So for your OSCEs, I added some cases from 2017 and 2018 at the very end of this presentation. And usually they'll specify take a menstrual history or take an obstetric history or take a sexual history, that sort of thing there. Okay, so you'll sort of know, okay, cool, if it's menstrual history, then I should have asked everything we had on the previous slide, as well as the symptoms that they're encountering, that sort of thing there. Okay, and then yeah. Okay, everyone's good. Next slide. Okay, so the next part we're going through is an obstetric history. Okay, sorry, that blurb is wrong. Sorry, that was meant to be for sexual history. Okay. But anyway, obstetric history clearly would be if someone's presenting and they're already pregnant. So in this case, you need to divide into sections. So you have to go through the progression of the current pregnancy and the progression of any past pregnancies, okay? So first thing you want to do is you want to ask them, do they know what their last menstrual period is? So for the last menstrual period, the date is the first day of their last menstrual period, okay? So that's used to calculate the estimated due date because you add about 40 weeks to that. Or if they're a bit more further along in their pregnancy, they should know their estimated due date and they should be able to give that to you. So this just gives you an idea of the gestational age that they're currently at. Second thing you want to do is you want to ask, how did you confirm that you were pregnant? Most cases will just be the fact that they missed their period and they just had a urine test and they might have gone to the doctors later to confirm it with a urine screen and blood test as well. You just want to make sure that they are actually pregnant. And then a third thing you want to ask is how did they react when they found out that they were pregnant. So this is something that I just added that's not something that everyone goes through. So you just want to hint at the psychosocial history aspect to it, okay? So just a bit of a side note. So whenever someone falls pregnant, most people always say, oh, congratulations. Don't say that. If someone says that they're pregnant as a patient, be like, okay, cool. How do you feel about that information? Okay, because obviously, it might be a planned pregnancy, it might be an unplanned pregnancy, they might be freaking out to the news, they might be really happy with the news, that sort of thing there. So you just want to know where are they at, okay, so you can support them as needed. Okay, so ways that you can sort of ask this question here is thinking about if the pregnancy was planned or unplanned. If it was unplanned, was it because the contraceptives failed? And if they are using contraceptives, you want to make sure that they're still not using the contraceptives. If it was a planned pregnancy, you also just want to know if they used IVF or any other assisted reproductive technology, so that you can support them as needed. All right. And then you also want to ask them about the symptoms of pregnancy. So there's a whole bunch of symptoms that I'll put onto the next slide. Other things you want to ask if they're up to date with the immunizations. So the immunizations you want to ask them about in particular is rubella, varicella, pertussis, and if it's in winter, you can ask them about influenza as well. So you just want to ask if they're up to date with their immunizations. You want to ask if they're taking any medications because some of them might be contraindicated in pregnancy. So, for example, if someone has epilepsy, then some seizure medications can't be taken during pregnancy. And you might just want to ask if they took any folate supplements. And if it's early on in the pregnancy, then you can suggest that they do to help with the neural growth of their baby. And then depending on how far along she is, you can ask if they had any scans or tests done. So for example, dating scan, morphology scans, nuchal translucency, which is done at 12 weeks, and so on. And you also want to know the results of any scans that they've had, okay? So that's what you're asking for a current pregnancy. So again, just sort of seeing how they are at with their current pregnancy, okay? Alrighty, so this one here, we're just going through pregnancy symptoms. So like menstrual symptoms as well, you need to know what's normal and what's okay and what's a bit more worrying, okay? Because obviously a woman's going to be pregnant, she has all these changes happening to her body. She's going to be freaking about every single one. You need to know which ones are okay and which ones are not okay. So normal symptoms are fatigue, mood variations, breast tenderness and enlargement, nausea and vomiting, urinary frequency, backache, weight gain, and swelling that is not excessive or sudden, okay? So these are normal symptoms which are okay. The symptoms that you might be a bit worried about is if there is excessive nausea and vomiting. Okay, so this might be hyperemesis gravidator, I think that's what it's called. So if they're vomiting a lot early in the pregnancy, that's okay. However, if they're vomiting to the point where they're constantly, having to throw up, then there's a strong risk of dehydration, that sort of thing there. So with normal nausea and vomiting, it's usually quite manageable when they just need a bit more, a bit of assistance, that sort of thing there. However, if it's quite excessive, then there might be a warning sign that there might be something a bit more, that they might be at risk of dehydration. Reduced fetal movement. So with a pregnant woman, she should know how often her baby should be kicking, that sort of thing there. So she'll get used to the pattern of how frequently the baby moves. So because of that, she'll know when there's reduced fetal movement. And if there is reduced fetal movement, that's a big flag sign because it's a sign of fetal distress. Vaginal bleeding is never normal. Vaginal bleeding is usually a worrying symptom because it could be antepartum hemorrhage, placenta previa, or cervical causes. Vaginal bleeding can be normal if they're having sex during the pregnancy. Other things that might be a bit more worrying is abdominal pain because it might suggest a UTI or placental abruption. Abnormal vaginal discharge. So by abnormal, a woman should know what her normal vaginal discharge is in terms of color and smell and that sort of thing there. Anything that's a bit more abnormal might suggest infection, so that might be a risk there. Looking at dysuria frequency or urgency. So we said that urinary frequency was normal. However, if there's any urgency or anything associated with it. It might be a UTI, and that's important because UTIs are very common during pregnancy, and because of that, you just want to check if they do have one. Yes. Yes. Yes, so leg swelling, yeah. Okay, cool. Yep. So in the normal symptoms, I mentioned that swelling that is not excessive or sudden is okay. The reason why I specified that was because if they have any headache, visual changes, or sudden swelling, it might be preeclampsia. So preeclampsia is high blood pressure during pregnancy, which can be quite common. And if they do have any of these symptoms, you just want to make note of it, just so that during the pregnancy, you're just monitoring them as needed. Okay. Yeah. So just like menstrual history, you just want to know what's okay and what's not okay. So you know what do I need to ask for, and what might be a bit worrying and what is okay. Okay, good. Yep, so these slides will be posted later, so it's okay. Alrighty. So that was the current pregnancy. So now you're also looking at the past pregnancies, okay? So there's two different things that you always want to mention. So it's always, whenever you have a pregnant woman, you want to state what's their gravidity and what's their parity. So parity, you ask this by saying, do you have any other children? So the difference between the two is that gravidity is how many times you've been pregnant, and parity is how many live births have you had, okay? So for parity, you just ask, do you have any other children? For gravidity, you want to ask, is this your first pregnancy? Have you been pregnant before? How many times have you been pregnant before? So if the maths doesn't add up, so say for example, if they said that they've been pregnant twice, but they don't have any other any children, then you might just want to ask gently if they've had any miscarriages or terminations, because these count to your gravidity. Okay, so if a woman has had one child and she's currently pregnant and she's had one miscarriage before in the past, that would be gravidity 3 and parity 1. Okay, and how you remember the difference between the two is that G comes before P in the alphabet, so gravidity is the one that becomes before, so being pregnant as opposed to giving birth. Okay, yes. So stillbirths don't count because it's a live birth. They don't. Yes. Okay, cool. So parity is how many live births you've had. Okay, so it's a bit confusing because the UK system does it differently, where they do the amount of pregnancies past 24 weeks. However, I'm pretty sure that in Australia they take it as live births. Okay. And then for each pregnancy they've had, you need to ask all of these questions here. So the date of delivery, the gestation at delivery, so you want to know if the previous babies were preterm, or if they were on the due date that was planned. You also look at the mode of delivery. Okay, so if it was at a normal vaginal birth, did they actually need to be induced? Was instrumentation needed, such as forceps or a vacuum to assist in the pregnancy? Did they have an elective C-section? Any reasons why they might have had an elective C-section? So say, for example, if the baby's positioning was wrong, or was there a need for an emergency C-section? If there were any problems before the birth, during the birth, or after the birth, so anything maybe like shoulder dystocia if the baby's shoulder was trapped or anything like that. And you also just want to ask how the child is currently doing. Okay, just because any of these issues here might come up again with a current pregnancy, so you just want to make note of that just so you can prepare as needed. Okay. Yeah, so lastly, when I sat in on a live birth, one of the ladies, her previous baby had shoulder dystocia as well, so that's when their shoulders got stuck because they were quite broad-shouldered, and as she was giving birth, this baby also had problems with her shoulders as well, so they had to use forceps for that pregnancy as well. So if you know what happened in a previous pregnancy, that just allows you to prepare well for the current pregnancy, just to prevent any major issues from arising. Okay. And other parts of the history as well. So because you're looking at a pregnant woman, you also just want to ask other questions relating to the other parts of your standard history. So for your past medical history, you just want to know if she's had any surgery, anemia, diabetes, or high blood pressure, because gestational diabetes and preeclampsia are quite prevalent, and you just want to make sure that if they do have these conditions, you can track them as needed throughout their pregnancy. If they've ever had any clots in the legs or lungs, or any heart or lung conditions. For your family history, you want to know if they've had any family history of twins. Okay, cool. When they're pregnant, you might, So when they're pregnant, you also want to ask if it's a singleton or if it's a multiple pregnancy as well. But anyway, going back to this, so for the family history, you want to see if their babies have been born with any abnormalities, if anyone has had any gestational diabetes, so gestational diabetes mellitus, or any high blood pressure in pregnancy as well. Okay, so essentially, with all the other women in her family, have they had any issues with birth or pregnancy or that sort of thing? So for your social history, you want to know about smoking, alcohol, and drugs. So obviously, she should have stopped all of these with her pregnancy. Some women might ask about whether they can still have any alcohol while they're pregnant, because they might be craving wine or that sort of thing there. How you would say is the fact that the guidelines recommend that no alcohol should be ingested during pregnancy. Okay. And social history. So this is a really good time to ask about relationships. So when you're taking the history of a pregnant woman, it's really important that you focus on the psychosocial history aspect of it. So I quite like, I'm quite interested in antenatal mental health, that sort of thing there. So when you're asking about, when you're taking a pregnancy history, it's a good time for you to actually, check on how things are going on at home, that sort of thing there. While a woman is pregnant is actually when most GPs and doctors would actually ask about domestic violence, that sort of thing there, because that's an instance in which a woman is quite frequently coming in to see a healthcare professional, and so it's a good environment to ask some questions like that. So you just want to ask if they have a partner, if they feel supported after delivery, home arrangement, that sort of thing there. So another popular station that might ask in your OSCEs is a station about postpartum depression, and that's because in Australia the number one killer or the number one cause of maternal mortality is actually postpartum depression. So that's why when you're actually taking your social history, it's a good time to ask about, the psychosocial history, like how are you feeling with the pregnancy, how are you feeling supported, do you have any issues or any concerns, because it's a good time for you to step in and arrange support for them as needed, to help prevent anything that might happen. But anyway, you also want to ask about drugs and alcohol, so in particular if they're taking any current medication, because like I said, some might be contraindicated in pregnancy, and you also just want to see if they're using any folic acid. Okay. Okay. All right, cool. And then the last part is the sexual history. So sexual history, I don't think it's it might not be that big of a thing in second year. However, I think it's still good that you guys should learn how to do it, because it's quite a popular station that they have in third year as well. So the sexual history, people tend to be quite awkward with it. I've had to be both the patient and assessor for a lot of mock OSCEs and mock ICE exams, and a lot of people are still a bit awkward about it, because I feel as if they don't know how to properly ask questions, or they might feel like they might be offending the patient, that sort of thing there. So this is sort of like a blurb that you can sort of have here. So I've been asked to take a sexual history from you. This is going to involve me asking you some questions which you might find uncomfortable. However, everything you told me is confidential within the boundaries of the team looking after your care. If you'd like me to stop at any time, please let me know. Okay, so this way, yeah, so this way the patient knows what to expect in terms of the questions that you'll be asking, and the fact that everything will remain confidential. Okay, so just a little blurb there. All right, so when you're taking a sexual history, main important thing is don't be awkward. If you're awkward, the patient's going to be awkward, the assessor's going to be awkward, the whole situation is going to be awkward, okay? So like I said at the start, there's a reason why you're asking these questions here. It's because the patient is presenting for complaint, and you're trying to figure out what their full medical history is so they can help them alleviate this, okay? Now, like I said, sexual history doesn't come up that much in OSCE, so don't take it unless it's indicated. So if they have the signs of an STI, which will pop up in the next slide. But anyway, with the sexual history, how you remember it is by going through the 5 Ps. So first P is partners. So you just want to know how many sexual partners have you had in the last 3 months. And just because they say, oh yeah, I have a boyfriend, doesn't mean that they might not have any other sexual partners. Because I had an ICE station where the patient had a boyfriend, and I just assumed that was her only sexual partner, but she caught an STI from someone that she went on holidays with, that sort of thing. Okay, so just asking how many sexual partners they've had in the last 3 months. Next, you want to know is about the practice. So how I usually word this question here is that sex means different things to different people. So what type of sex are you engaging in? Is it penetrative, oral, anal, digital? If they think that this is a bit intrusive, just say something like, oh, well, you know that different types of sex are associated with different types of different types of sex makes you higher risk for certain types of infections or diseases. So I just want to know the full picture so I can see what's going on. Okay. And you also want to ask about protection. So what protection are they using? And you just want to ask, are they always using? Okay, so usually they'd say that they're using condoms. So you just want to make sure, are they using condoms most of the time, or are they using it all of the time? Okay, and this is probably a good part when you would give a bit of counselling about the importance of using condoms, that sort of thing there, because a popular station for the ICE exam is that someone might just be using the pill and that's it because they're with a boyfriend, and you just need to add the fact that while they might be on contraceptives, it doesn't protect them against STIs, which is the main thing that we want to target here. Okay. So fourth P is looking at any past STIs. So you just want to see if they've ever been screened for an STI. So for young women and young men, they should be screened for chlamydia once every year, and that's using a first catch urine test. And you also just want to ask if they've ever had an STI before as well. And then finally, the last P is pregnancy. So essentially, you just want to know if they've ever been pregnant before. If they have, you just want to confirm gravidity and parity and maybe see what happened there. Okay. So sexual history, just remember the 5 Ps, and that's a good way to know that you've targeted everything. Okay. Alrighty. And just so you know, presenting complaints of what might cause you to go through a sexual history. So people with a vagina, it's mainly just vaginal discharge. or vulval itching or anything like that. People with a penis, it would just be pain in the testes or scrotum, swellings, itching or sore skin, or any skin changes. Okay, so if it's anything down there, that's usually an indication that it could be an STI, and because of that, you might just want to ask a bit about sexual history. Okay, but like I said, for the OSCEs, for an OBGYN station, it'll be most likely pushed to go through a menstrual history or obstetric history instead. Okay, and then yeah. Okay. Alright, cool. Alright, yep. So these slides will be on to the page as well. Alright, so that's pretty much all the 3 types of histories that you'll be asked, so that you'll be expected to know. So obstetric, menstrual, and sexual. So like I said, focus more on menstrual obstetric because that's what the OSCEs will mainly focus on. So when you guys are actually sitting at your STEM, make sure you have a piece of paper, and it's a good idea to just write down the types of questions that you might be asking them, okay? So what questions you might be asking from an obstetric point of view, and what questions you might be asking from menstrual history, okay? So for the OSCEs, you only have like 7 minutes for the history itself. So because of that, there's a lot of things that you could ask in a history related to OBGYN. So you just need to know what's the important pieces of information that I need to know. So for most stations, they'll be nice and they'll say specifically, oh, it's a pregnant woman. So that means you'll know that it'll be an obstetric history. Other times it might be someone that wants to be pregnant or someone that's a bit concerned about their period. So that's when you know, okay, cool, it'll be more of a menstrual history. Okay. So for the OBGYN stations for the Year 2 OSCEs, like I said, that's what the history will be. For the examinations, there's no examinations related to OBGYN. So because of that, most of the time it'll be a woman coming in because she's like 12 weeks pregnant. So you'll just be doing routinal things, okay? So you might be asked to take a blood pressure, take a heart rate, take a temperature, take a pulse, use a peak flow meter, as well as urinalysis, which is what I'll go through. So just make sure that you know how to use a blood pressure machine, and make sure that you're used to that with your temperature, you're used to using all the different types of thermometers they have, and with the peak flow meter, know the different things that might cause different values for different people. So the height, the sex, that sort of thing there. Okay. And with the peak flow meter, you take 3 and then you take the highest one. Okay. But anyway, so for urinalysis, it's something that they'll commonly have with OBGYN because they're quite related to each other. You take a urinalysis to check for any gestational diabetes in pregnancy, and also if there's any UTIs. Okay. So just going through the steps of how to conduct a urinalysis. So you might be asked to describe to the patient how they should actually collect their sample. Okay. So the steps you have here is you tell them to wash their hands. They need to open the container, make sure that they don't actually touch the inside. And using antiseptic wipes provided, clean the head of the penis or the inside of the labial folds, front to back. If it's a man, they should pull back the foreskin. They should let some urine go into the toilet, stop, and then fill the cup to about halfway. Okay, so midstream urine is for most urinalysis. When you want to check the urine, check the properties of the urine, you'd only use the first catch if it's for an STI. Okay, so this could be a Viva question that might ask. The reason why you don't take the first catch is because it's because it would be more related to the genitalia when you want to check the urine itself, okay? And with the patient, you just tell them to put the lid back on and return the sample to the healthcare worker. Now, if you want to be a bit extra and you have a female patient, you can be like, oh, are you on your period? Because if they are and you do take a urinalysis, it'll be a false positive for hematuria, okay? So if you want to be a bit extra, you can just ask if the female patient is on her period as well, okay? So this is the steps that you would do. Yep, so just make sure to be antiseptic and make sure that they're actually taking a midstream urine sample, not a first catch urine sample. Okay, so like I said, these slides will be on the page as well. All right, so the second step is the part that you'll have to do. So it's actually reading the sample itself. So you need to wash your hands, put on your gloves, check to see if the dipstick is expired. It will be for the OSCEs. So you can just say something like, ideally I'd be using a dipstick which isn't expired. You want to confirm that the patient name on the cup relates to the patient that you have. So what you do is to take the dipstick, you'll dip it into the urine and you leave it in for about 5 seconds. You want to pull it out at an angle to the container and wipe it on the edge of the cup. Now ideally you'd leave it on a tissue for 30 seconds just to dry so you can read it properly, but you don't have any time. So you just say, ideally I leave it to dry for 30 seconds. However, in the interest of time, I'll just start reading the dipstick itself. So you just want to compare it to the markings of the container and you'll just comment on each result that you actually have there. Okay, so this is the part that you'll most likely be expected to do for an OSCE station. For the explaining part, it's an extra step that I might ask you to do, might not. Okay. And then so for the next I'll be going through all the different things that you're checking for in a urinalysis. For the OSCEs, it's usually just asking you to check what the glucose is. with the stem being that you're looking at a pregnant woman, she has a urinary frequency, and they just want you to comment on the glucose that you noticed in the dipstick. Okay. And then, so urinalysis tends to be quite easy. It's just a matter of being able to explain what the steps are and just making sure that you're interpreting it properly. Okay. Alrighty. Okay, so what do the different results mean? So as you guys would remember for H and B, there's a whole bunch of things that they actually go through in the urinalysis screen. So things like specific gravity. So this just determines the presence of solutes. So the more solutes there are, the higher the value would be. So the normal urine range should be about 1.0 to 1.030. Okay. Second thing is pH. So normal urine is acidic and normal urine is acidic with a pH rating of 5. So this is a Viva question they've asked before. pH can be affected by drugs. Protein can be normal if it's positive because 150 milligrams is lost in the urine. If it's abnormal, it might be glomerulonephritis, fever, exercise, or congestive cardiac failure. Like I said, you don't need to know what abnormal protein might mean. I just put it in there just so you guys have an idea of why we test for this sort of thing or why we ask that certain question. Okay, erythrocytes might point to infection, cancer, kidney disease, or kidney stones. Other parts of the results, you're looking at glucose. So if it's positive, it might be diabetes. Glucose can be positive. Positive glucose in pregnancy can be normal. However, if it's above a certain range, it could be gestational diabetes. Ketones suggest excessive fatty acid oxidation, diabetic ketoacidosis, or starvation. Hemoglobin, if it's broken down, so you break it down into if it's macroscopic or microscopic, and this might indicate glomerulonephritis, hemolysis, cancer, infection. Nitrites indicate that there could be a bacterial infection, so they might have a UTI, and then leukocytes indicate infection or cancer. Okay, so like I said, you don't need to know what this result could mean, you just need to comment on it. Okay, so when you're actually doing it itself, you just report back as you go, because if you have to like comment on every single thing, you might forget. So just say that glucose is a bit elevated, ketones are normal, hemoglobin is normal, nitrite is normal, leukocytes is normal, So this is stuff that you get based off the urinalysis itself. You can also comment on the color of the urine itself. So if it's red, it's hematuria, hemoglobinuria. If it's black, then it's severe hemoglobinuria. If it's brown, that'll be bilirubin. Yellow, orange, it's concentrated or bilirubin. Pale, colorless, it just might be diluted, or it could be diabetes insipidus. If it's turbid or cloudy, there could be excessive cellular material, or it could just be because of the fact that the salts have crystallized because it's left standing in room temperature in a refrigerator. Okay. And then so for most of the cases for urinalysis, you guys will just have a fluid, and it will mainly just be the fact that there'll be elevated glucose or something like that. Okay, so that's just something you can comment on the color if you'd like. And because we have time, I just thought I'd go through the past cases just so you guys sort of know what they might ask you in OBGYN stations. This is from 2017. So for the first part, it was someone who wanted to start a family for her husband and comes in for a general checkup. She's been having some headaches recently. Take a full medical history, including a menstrual history, and ask her for her use of contraception. So like I said, they would specify the types of history that you'd be taking. So when you guys have your reading time outside of the station, actually use that properly. So just write down the types of questions you want to ask, okay? So she wants to fall pregnant, so because of that, you want to take a menstrual history, check to see if her period is regular, because if there's any disturbances, it might indicate that she might have any underlying gynecological conditions, which might be the reason why she might not be why she might have issues falling pregnant if she is. And you also might want to ask if she had any past STIs, and even though she's coming in because she wants to fall pregnant, you might just want to ask about gravidity and parity still, just to see if she's been pregnant before, if she had any issues of falling pregnant with her past pregnancy, and so on. They also want to ask about her use of contraception, so that's one that I probably should have also included as well. They might want to ask you about the different types of contraception you guys that would be available to a patient, so things such as the oral contraceptive pill, as well as other things such as an IUD. Okay. Another station they had in 2017, so it will be a pregnancy checkup. So like you see here, when you have an OBGYN station, the corresponding examination would be something like pulse, temperature, urinalysis, and in this case, you'd have to explain the midstream urine collection interpretation as well. Okay. And asking this one here, it's quite a normal pregnancy, that sort of thing there, and the vibe was just about the normal pH for urine. Okay. So when you're taking a history, if there's anything that's a bit of a if there's anything that's a bit outside of the curve, so if they're saying something like, they've had a miscarriage before, just ask a bit about those extra things, because that's usually something they want to test, whether it's like your psychosocial history or your empathy with that section there. Okay. And then from last year, so as you can see, the first section was actually postpartum depression. So just looking at her coping and her concerns there. So you just want to see how they're coping with the pregnancy, how they're coping after the pregnancy, any support they have, and as you can see, the examination is just the typical things we have there. Someone else is presenting with urinary symptoms who's also pregnant, and again it's just the general checkups, that sort of thing there. And the last case was just a basic OBGYN history where you're looking through things. As you can see, there's nothing really significant, and then you just have to measure pulse, air temperature, and dipstick, and glucose only. Okay. And then so those are just the types of cases that they had from the last 2 years. As you can see, it's quite standard things, just going through a basic history, that sort of thing there. So when you guys are practicing for OBGYN, just practice taking a menstrual and obstetric history with each other. There should be past OSCE cases on Medconics. If not, there's still past ICE cases, which you guys can use to practice, which are good because they have the assessor and the character sheet, so you guys can actually practice with each other. Most of the times, the history findings will be non-significant, as in the fact that everything will be quite regular and quite standard. Okay. And yes.
So what does it mean, like the Vivas factors that affect the...
Oh, sorry, that probably meant peak flow rate. And then so it'll just be stuff like height and gender and that sort of thing there. And then okay, cool. Yeah, so then for Vivas, it's just extra stuff based on what you guys want. Okay. So we have like 40 minutes. Do you guys want to go through an otoscope exam as well for BG? Yeah. Okay, cool. So we'll just go through it just because we have extra time. And then so for the pediatrics element of BGDB, what they want you to do, so this is just straight from the CS guide, is they just want you to take a history of a child's illness. So this will be done through a parent. So you're not going to have any children for your OSCEs. You can have them for your ICE exam. However, you can worry about that next year. So you just want to ask it through a parent. And the thing that they really emphasize in the guide is that you just want to assess the impact of the illness on the child and the family. So as you know, whenever you're asking a history, you just want to show that you are actually empathetic and you're not treating the patient as like someone that's there. So you want to treat them as a human. So you just want to ask, how does this make you feel? How are you coping with this? So especially during OBGYN and peds, that's when you really want to ask, how they're going, because it can be quite emotional for them. Okay. So for a pediatric element, what you want to ask about for the child is you want to ask about the antenatal and birth history. So essentially, were there any complications with the pregnancy? So any gestational diabetes, preeclampsia, that sort of thing there. With the birth history itself, were there any issues before the delivery, during the delivery, and after the delivery as well? You want to check the immunization status of the child. So are they up to date with the immunization? So it's important that you guys know roughly the general guide of which ones they should have had by the age that they're at. You also want to ask about the developmental history. So obviously there's a whole bunch of developmental milestones. I think it's easy if you just remember the red flags. So they should be like walking by one, that sort of thing there. So there should be developmental milestones, red flags. If you guys remember those, that'll give you a good indication of is their child up to date with the development. Another thing you can ask is if they're worried about their child's development, because their children will be hanging off other children. If their child's a bit slow, then they'd notice that. Okay. And also any family history, particularly anything that runs through the family that might affect the baby, such as like if they had asthma or anything like that. So just want to expect you to understand the approach to assessing child's development. So make sure you do know your milestones, especially the red flags. And the examination you'd have for pediatrics would be an ear examination as well as a throat, because you usually do them in conjunction with each other. Okay. So like I said, you won't have a child when you're doing the ear examination. You'll be doing it on the parent as a proxy for their child. Okay. So for the ear examination, something like that. Yeah, so for the otoscope exam. So with every single examination, you just want to wash your hands, you want to introduce, and you want to make sure that you're actually explaining the exam properly, okay? So when you're doing any exam, you need to make sure that you're actually explaining what you're going to do in the exam. If you're doing abdominal history, you can't just say, I just want to have a look at your tummy, because you're going to be pressing on their tummy, doing all that sort of stuff. Okay, so in this case here, you just say something like, I've been told that your ear is giving you some trouble. I'd like to have a look at the outside of your ear, and then look inside and use my otoscope. Show them what the otoscope is. It can look a bit scary, so you just say that it has a light attached so I can see clearly, and it shouldn't hurt when I insert it. Is that okay? Okay, because in order for them to properly give consent, they need to know what you're doing to them. Okay, so before you actually do anything, you just want to ask if there's any discomfort in their ears, and you want to examine the non-painful or the better ear first. So just test that the otoscope is working. Make sure you practice how to turn on and turn off the otoscope with the ones I have in the CS rooms, because otherwise you can waste a lot of time if you're fiddling with them in the exam, like I did when I was in second year. So the patient has an infection in one ear. You just need to make sure that you change your otoscope tips before examining the other ear. However, you should be starting with the normal ear first anyway. All right, and also remember that whenever you're using your otoscope, you want to have the hygienic tips attached. So first thing you want to do, general inspection, is just inspect the ear. You want to compare symmetry between both ears. Notice if there's any deformities, any signs of active inflammation. So if it's red, inflamed, if there's any discharge that you can visibly see. Comment on any ear piercings you want in case that's a cause for any infection, as well as any scars. You also want to inspect the mastoid behind, so just looking for any skin changes, erythema, or any scars. And for the periauricular part, just looking for any pits, sinuses, or fistulas. So essentially just looking at the ears. Are they normal? Is there any deformities that you can note based off general inspection? Okay. So for the OSCEs, all of your patients will be normal. If someone has an ear infection, they won't be used for the OSCE exam. Okay. So most of the time, general inspection, there'll be no significant findings there. Okay. So that's a general inspection, and then we're actually going to go into the ear using our otoscope. So you want to ensure that the otoscope light is working, so just test it and flash it on your hand, and you want to apply a sterile speculum. So if it's an adult, which it would be, you just want to pull the pinner up and back. If it's a child, you only need to pull it back because of the fact that their ear canals are quite horizontal. Okay, so you want to pull it using the opposite hand, because the same hand will be the one holding the otoscope. So if you're looking at the left ear, then you're holding the otoscope using your left hand, and so you're pulling it back using your right hand. Yeah. So when you pull it out, if there's any pain, you want to note this because that's quite a significant finding. You need to ask the patient to remain still because you don't want to accidentally hurt the ear while you're inside. So you want to position the otoscope at the external auditory meatus. So you're holding it like a pencil, and you want to rest it on the patient's cheek for stability. That way, if anything happens and you get pushed, you're not going to be pushing the otoscope further into the ear. Okay, it's going to be stabilized there. Okay, so when you're looking, so you look through and you want to slowly advance towards the tympanic membrane. You want to make note of any wax, swelling, erythema, discharge, foreign bodies, or any bony swellings that are present. And then when you actually get to the tympanic membrane itself, you just want to examine the 4 quadrants, making note of any color. So it should be pearly grey and translucent. Erythema or bulging membrane, perforation, scarring, looking at light reflexes and any abnormal growths that you might see there. Okay, so you can also mention the fact that you see the handle of the malleolus and the cone of light as well. Okay, so that's what you're doing when you're looking through the ear canal as well as through the tympanic membrane. So just some photos so you know what you should be looking for. So that's a normal ear that you have there. So as you can see the head of the malleolus. You can see your cone of light there. So the cone of light should be about at like 5 o'clock if you're looking at it as a clock face. So just look at the 4 quadrants that you see there and note any issues that you have there. What we have on the right, it's a sign of acute otitis media. So as you can see, it's quite red. We can't see the cone of light in its normal position. So as you can see, it's just quite red, and you can see all the vasculature that we see there. Okay. Other things you might see, or other pathologies that you might have as well. This is what we have, which we call glue ear. So that's when the middle ear is filled with a glue-like fluid. So because of that, that's the presence you have here. Down here, what we have is a bit of scarring on the tympanic membrane. Up there, we have a grommet. So a grommet is something that they used to put in kids who had recurrent ear infections just to help drain it a bit easier. And the bottom right is just earwax. Okay. And yeah. Cool. And then and this was some. Okay, cool. And if you look at the first and third ones, these are examples of what they might ask you during a station for peds. So for the first one, it's just someone worried about their 6-year-old child who has had recurrent ear infections, cold, fever, and a sore throat. Oh, also, so sorry. So for the throat examination, when you're doing it, again, you're just using the otoscope as a light. So you just want to use the paddle pop stick, pull their tongue down so you can have a look at the tonsils. See if the tonsils are inflamed or swollen or anything like that. And that's what you would do for the inspection of the throat. Okay? And then, so in this case here, you're taking the history of a child to their parent, and then you'll be examining the parent's mouth, throat, tonsils, and the ear using an otoscope. And then they might also ask you to do a cervical lymph node examination. So as you can see, you also need to know all the extra things. So for cervical lymph nodes, just make sure you can name them, and you can practice doing it with your friends. Okay? The vitals are just the location of the tonsils, and to name the other groups of tonsils as well. And then for the third one, that's another peds history. So just worry about a 6-year-old daughter's persistent cough. So those are just features there. So in this case, you're just doing your normal respiratory exam, but just doing it on a child instead, and just asking about any issues with developmental antenatal history or any issues there. And then in this case, you just perform a respiratory examination on mom, and as well as the respiratory rate. Okay, so that's what you're doing here. And yes, as you can see with OBGY stations or ped stations, it's essentially just doing a couple of extra things. So for your obs stations, just make sure that you know what type of history you're asking, and make sure you know what questions do I need to actually ask and why am I asking this question here. Okay, so menstrual history, you just want to characterize the type of period that they're having. For an obstetric history, you just want to see how they're progressing with the current pregnancy, any complications they might have had in past pregnancies, just because you might need to flag them for the current pregnancy. And with the procedural examinations from an OBGYN, it's fairly standard. For urinalysis, you need to know how do you explain to the patient how they collect their sample, how do you analyze their sample. And then for the BGD section, you just need to know how you take a history through a parent, making sure you ask them about the antenatal history, development history, and if the child is up to date with immunizations, as well as any other children they might have. And then for the examination part, we'll just be looking at the otoscope as well as looking through the throat. So for that, as it gets closer to OSCE's time, just practice a room in the clinical skills room. Practice using the otoscope on your friends, that sort of thing there, just so you can know, oh, you know, that's what the cone of light looks like, that sort of thing there. As I said before, for your OSCE stations, most of your patients will be normal, so there won't be any significant findings. For a second year, you guys should also practice how to do summaries, because some 30s are still quite terrible at how to do a summary. With a summary, like I said, because your OSCE stations, because they tend to be quite normal and quite standard, there aren't going to be any significant findings. So because you don't need to say that the patient had menarche at 12 and has a 7-day period, has a 28-day cycle period that lasts for 7 days. You can just say that there's no significant findings. Okay. So Beryl, I think, posted a document onto Medconics which just has a summary for each exam. So I just memorized that and just spat that out for every single station that I was at. Okay. Just because if you have a summary that drags on and on, that's not a summary anymore. Okay. And then yeah, okay. All right, cool. So that's all I have. Do you guys have any questions about the OSCEs in general, or OBGYN or peds? Yes.
So
Yeah.
if the STEM is about a child with an ear infection,
Yep.
should you do your normal presenting plate
Mhm.
history, about pain and
Yep.
stuff, and then ensure you follow up with the
Yep. Okay, cool. Yeah, so whenever you're doing the OSCE stations, always pinpoint what exactly they want you to ask and make sure you go to that, because that's where all the money is, right? And then with 7 minutes, you usually have enough time, so just ask a few questions about antenatal. Most of the times, everything else will be normal, because they want you to spend most of your time on the thing that they're marking you for, okay? So based on the STEM, just listen to what the STEM wants and do that, okay? And then just ask the extra things if you have time. Otherwise, I wouldn't worry too much about it, okay? And then any other questions? No? Yeah. All goods. All right, cool. All right, thank you. No worries.